hook it up to the heart-lung machine, and if you go through, it's about that big around, and it has a big vacuum on the end of it, and you put it up there and turn the heart-lung machine on, and hopefully it just sucks the clot out, not their whole lung. And then a rheolytic thrombectomy, it kind of makes a vortex, it's got some ports on it, and it makes this little whirlwind, and it breaks up and aspirates the clot. And you can, any of these, you can use them with or without the TPA. There's been a meta-analysis of this done by Dr. Kuo, and he found 594 patients. It was 86% effective on a clinical basis. These are all massive, we're talking about massive PE patients here. 86% clinical success, which was they lived and their hemodynamics improved, and there's a couple other components to it, but basically they did good. Was 86%, and 95% of them did not have systemic thrombolysis given, which is a little weird because starting in 2008 it was an official recommendation to give it, as long as there's no contraindication, and it may be that a lot of people had contraindications or whatever, or maybe they just weren't following the recommendations. So that's it for PE, and I'm going to just quick mention a couple things about DVT. The reason for anticoagulating people with DVT is not only resolution of DVT, but prevention of pulmonary embolism. The rationale for getting rid of the clot in an interventional fashion is really just to avoid the long-term consequences. I don't think it's ever been shown to reduce pulmonary embolism. In fact, sometimes I think there may be some studies that show it actually increases pulmonary embolism because you're breaking up the clot and maybe it'll be free to travel to the lungs. We can talk about that for days too. But so essentially the reason that the long-term outcome that you don't want is called post-thrombotic syndrome. And it's a combination of the valves don't work in the veins anymore because of the damage from the clot, and the clot itself will many times cause an obstruction or at least a stenosis in the outflow veins from the legs. It's a combination. Sometimes it's just one or the other. Many times it's a combination. Generally, in the people that have severe symptoms, they have a combination of reflux and obstruction. So, and the pathophysiologic end result that causes the problem is called ambulatory venous hypertension. So high pressure in the veins. It particularly happens when you walk, because of gravity, and then when you walk, there's more blood going into your legs, and the body actually is designed to get rid of more blood when you walk, because when your calf muscles contract, it squeezes the veins, and the whole idea is the blood gets out of there, and then the valves keep it from coming back. But if you have reflux and obstruction, either the blood won't go out or it comes right back when the calf muscles relax. It can be mild with pain, edema, and heaviness, those sorts of symptoms, or it can be much more significant with, you've seen the people with legs that look like cauliflower. They, really all these skin changes, or they can have ulceration, and those are obviously problems. But a lot of DVT patients are young, relatively young people that are still working. And so when you have a leg that swells and it hurts all the time, or it hurts when you walk, sometimes what may sound like somewhat mild symptoms result in a lot of loss of days working and some of these other things. So it's, from a societal standpoint, post-thrombotic syndrome actually has a pretty remarkable effect, I guess. Somewhere between 30 and 80%. I love the percentage ranges that are so wide that, well, it's 29%, that's not that bad. If it's 80%, we ought to, have a whole society dedicated to it or something. But anyway, so a lot of people will get some degree of PTS after a DVT. Somewhere between almost nobody and a whole lot of people will get severe symptoms. But the number of people that get ulceration, which is a really sort of a much more severe aspect to this, is probably in the 5% range. If treated with anticoagulation alone, iliofemoral DVT is what you really worry about for getting this PTS. People that have a popliteal DVT or something, typically they may have a mild form, but the people that get the real severe problems with it are the iliofemoral DVT, because that's sort of the common channel where everything from the leg, the superficial and the deep venous system, have to drain through the iliofemoral veins. So if they're treated with anticoagulation alone, 90% of them will get ambulatory venous hypertension, like if you test them in the office. Maybe less than that, but a whole lot of people will get symptoms. 40% will get venous claudication, pain when you walk, and then about 15% of them will get ulceration. So you can see it's a more severe group of people because those percentages are higher than the ones for all comers with DVT. In terms of interventional therapy, either you're putting the catheter in, doing a pharmacomechanical thrombectomy of some kind or another, does seem to be very effective in getting rid of clot, either complete or near complete removal of thrombus. In several papers, there's been a lot more than these, show between 70 and 90% will be either completely or mostly resolved. And then partial clot removal, I don't know how much that helps people, but and most of the remaining patients will have at least some clot removed. The good thing is that they have insurance to get paid for all of them. But I'm just kidding. Because you're using a fairly low amount of the agent, they have a pretty low, not zero, but a pretty low risk of bleeding complications from these. There's no long-term data as far as 5 years or 10 years down the line, how many of these people do not get post-thrombotic syndrome, but certainly stands to reason that if you get rid of the clot early, there's less chance that if you totally get rid of it, then there shouldn't be any, there should be very little chance that the vein would get damaged and the valves wouldn't work. But sometimes what seems like it would make a lot of sense doesn't turn out to be the truth when you study things, so you can't say it for sure. But and the effects are better in younger people and lower risk in younger people too. However, the CHEST guidelines, even the most recent ones from 2000, it's actually 2012, not 13, do not recommend catheter-directed thrombolysis for even proximal DVT, iliofemoral DVT. But then they have the caveat that a patient that cares more about not getting PTS and they don't care how much it costs and they don't mind bleeding would probably want to have catheter-directed thrombolysis. I don't know. And this, one of the guys, it's funny because Camerota, if you'll notice, it writes, he writes, this is one of his main, he's a vascular surgeon, he does a lot of venous work and he's considered a big authority on venous disease, particularly DVT. And it's kind of interesting that he is one of the authors of the CHEST guidelines. So I bet those meetings were really heated because he's written articles that say these guidelines are ridiculous, that you can't do it because all the data shows it helps, and why is it this way? So it would be fun to be a fly on the wall when they're all meeting and he's going crazy and they're saying no. But anyway, so that's all I have. I hope it wasn't too disjointed. But I guess my conclusion in terms of the PTE is it certainly seems to have a beneficial effect on the hemodynamics. It hasn't been shown yet to have a statistically significant reduction in mortality, even for massive PE, although there is a trend in that direction. There's a lot of trials that are ongoing and may show that there's a benefit to doing it even for the submassive patients. I'll keep offering it in appropriate patients who seem bad enough to get it.
Anybody else? You guys have questions? Dr. Manny and I have questions. We both
Hard
wondered.
questions, okay.
No, we want to know about filters. It seems like every time we get somebody who has ECT, we always get the recommendation to throw a filter in.
Really? From who? Not from us though, right? Usually from
You
us.
want to handle this, Rick? You're more senior than I am.
Oh, from the vascular surgery department.
Okay. Those guys.
So,
Maybe it's that so the indications for filter, you know what they are. I mean, it's, you can't anticoagulate them, or you anticoagulated them and they had another event. Those are the absolute indications. The soft indications or relative indications are, let's see.
Good man. He looks at his evidence-based medicine stuff.
Oh yeah, no, I was actually looking at my text message. I did. You could have the filter was memorized because we got so many filter consults in Memphis that I mean, you just do filters all day if you put them in everybody that asks for it. The soft indications are, you think they're high risk for anticoagulation, like they might fall, that sort of thing. And although the CHEST guidelines say even in high risk patients, they should still get 3 months of anticoagulation. And then trauma patients that can't be anticoagulated because they're polytrauma patients are such high risk of DVT, and if they have an intracranial hemorrhage, you can't anticoagulate them. So, and a lot of the patients with the soft indications or the relative indications end up getting removable filters. This may change. They're always trying to come up with new stuff, but it looks like the removable filters, if you leave them in, actually are worse than just leaving one that's meant to be left in longer. And there's so many things at play with the filters that the other thing is that up until like a year or two ago, they reimbursed very well because it was in the same category as vena cava interruption, which they used to do that for recurrent DVT or PTE. They go in and just tie your vena cava off, which is a major procedure. And putting a filter in takes about, a minute and a half. And, so a lot of people were, very excited about doing filters because it's, for your time, you can make the most money. I mean, I'm just saying that's the way it happened. And so now they cut it to, much less, but still probably worth your time to do it. But I think that part of it is the societies have come out and as, the National Inpatient Sample and other things show that there's a lot of filters being put in. They've kind of decided to look at, wait, hold on, a lot of these people don't really have a firm indication to do it, and maybe a lot of them really didn't have much of an indication at all, and we need to look at that because not only did they not have a reason to have it, a lot of them are having problems, filter fracture, filter thrombosis, migration, whatever. Even if it's 2% or whatever, if they didn't have an indication, that's they shouldn't have any risk. They shouldn't have a filter at all. And so there's more studies now being done to evaluate how what are the settings in which filters are being put out or being put in, and what should we do about it type thing. American Venous Forum is kind of a hot topic for all of them. My thought is, I think we ought to be fairly conservative about it. 1 second. Hello? Hey. Yeah, but y'all can go ahead and do what you gotta do. Yeah, sure. Give me just a few minutes, okay? All right, thanks. I think we ought to be pretty conservative with it. Now, in Memphis, I would always, really try to get to the bottom of it, and do we need to do it or not? And then I go tell my attending, they don't really have an indication. He's like, well, look, either we're going to do it or radiology's going to do it, because if they ask radiology, they're just going to do it. So we'll do it. And at least a few times we would get somebody down in the cath lab ready to do it, and the first little fluoro shot, you step on the pedal, it'll come on, and they already have a filter in it. So those were short cases usually. But my thought is if you have an absolute indication to do it, sure, yeah, they ought to have it. If they don't have an absolute indication, it's hard. I always feel a little rude telling, the primary doctor that's taking care of the patient. They've been taking care of them for, sometimes years, or at least, a few days since they've been in the hospital, and they've decided the patient needs a filter. I always feel rude saying, hey, this guy doesn't need what you think they need. But I do, if I don't think they need it, I'll make that opinion known and say, if you strongly want it done, I'll do it, but I really don't, maybe I don't think they need it done.
So
what do you think?
My again, opinion, and the people see a lot more patients here than I do, is that we sort of get the other, we ask because we don't really think they need a filter, but we just want to make sure, and the next thing we know, they've got it.
They've already got one in, yeah.
So
Well, it may be that,
I could be wrong, and you guys disagree with me if you want.
I'm hoping that that's not me, but maybe it is, but if the other guys may think you're asking for a filter, like work order, put a filter in. If that's not the case, then I'll mention it to them, and I think y'all should talk to them to say, look, when we ask about a filter, we'll make it clear. We just want to know what you think, whether they need it or not. But part of it is, I mean, if it's a relative indication, then it's the assessment of what their risk is of bleeding, or whether they shouldn't be anticoagulated, or they've had such a bad pulmonary embolism that if they embolized at all again, it would probably kill them. Those are kind of these soft indications that maybe I guess a lot of times we feel like that determination should probably be made not necessarily by us. I mean, we ought to be involved in it, I don't mean that, but a lot of times we don't know. Well, obviously, we don't know them at all until you call us, and so a lot of times we don't really have a understanding of that risk for the individual patient.
So see if I've got this right. To briefly paraphrase, if they've got a big DVT, we can ask you guys to go in and lyse it. But as long as we can give them anticoagulation, they really shouldn't be getting a filter?
For filter, my opinion is if they can be anticoagulated and they have not had an embolism while on anticoagulation, then I think it's a very limited number of people that need a filter.
Thank you.
And it's a judgment call, but. And in terms of the thrombolysis, that is a situation where it's much more us, and talking to you guys and but making a determination of what the risk is and what the benefit potentially is. I mean, they're non-ambulatory. I mean, because all we're talking about is avoiding this post-thrombotic syndrome, and you got to be usually a few years out to get it, and you have to be a few years out from your DVT. So, you know, you have to have a pretty good life expectancy. You should be a fairly functional person that is going to really have problems from the post-thrombotic syndrome, and he should be so you're kind of young, fairly functional, and no contraindications to the agent. So it's kind of a limited. We like to do things that work. We don't like hurt people.
From your talk, you mentioned all these studies. Did they mention how bad of the pulmonary hypertension? Did they have numbers or just like 40, 60?
For the
rating, like some
long-term,
massively went to low, not to low. Like they say RV dysfunction, pulmonary hypertension, but how would we decide if it's bad?
how you decide clinically? You're asking me how do you decide who
Yeah,
to
on
give?
echo, like is there some cutoff that the studies used as numbers, or it's just?
Yeah, for for RV dysfunction, there's the ratio. Now I've got echoes I've gotten here. They don't mention ratio. They just say RV dysfunction or hypokinesis or elevated pulmonary artery pressures. On a pulmonary artery mean pressure greater than 20 is considered pulmonary hypertension, in my understanding. But there aren't not many people that get a right heart cath for a PE. Measurement on echo, I mean, they measure the pressure. It's hard to know, I think certainly if it's over 30, it's probably significant, but it's hard to know on the echo what really, so I usually just read what the cardiologist says, and if they say there's dysfunction or pulmonary hypertension, they have it, from my standpoint. In terms of, what else did you ask about? So pulmonary pressure mean pressure over 20.
Like if they have it from before from something else?
They certainly could. Yeah, and a certain number of people that have a PE have had a previous PE, and they may have pulmonary hypertension from that. I guess maybe some of them could be primary. That's probably it's not all that common a problem. So to have that and a PE is probably a really small percentage. So.
Thank you very much.
You're welcome.
Thank you very much.
Yes, sir. Glad to come back and talk about chronic kidney stuff.
Yes, please, that would be great.
Thanks for having me back.
So, I feel like torturing you guys because you all are here. This is like the biggest crowd we've had, so hooray. Ms. Gamble, are you good? Do you know how long you're going to be talking?
10 minutes.
Okay. Because I'm trying to decide. You guys sit your butts back down. Not really. Because I'm trying to decide. Because I know when I give them a break, I'm going to lose some, and I'm going to have some important announcements to make. So can we do a break and then you start our next session? Cam, why don't you go first now with the announcements?
Just knock it out right there.
Just knock it out.
Super fast, guys.
You're welcome.
All right.
Everybody knows who Cam is, right?
I think we most do.
All right.
And I'm your IT guy. Anyway, join here once to be able to access their schedules from anywhere in the